Thanks very much. So I'll get right into the program. These are the things we're discussing today, and with this sophisticated audience, I'm not going to prolong these issues. What I want to draw attention to, and I kind of hinted at it a little bit in the last talk with the Norwegians, is a lot of what we do is dependent upon us as surgeons. Yes, we work in an MDT, but ultimately when we go into the operating room, it is up to us to perform the best operation we can. And unfortunately, that's not always the case. Even more unfortunately, we've known it for a long time, but only recently in the US have done something about it. So here's an example where in Canada, and these are data that started 30 years ago, 40 years ago actually, 1983, concluded 30 years ago, where 10% of the surgeons are colorectal surgeons. And what we found is that people who were trained in colorectal surgery tended to tackle lower tumors, despite operating more frequently on lower tumors, were less likely to perform abdominoperineal resection, more likely to perform restorative resection. And then when the variable was added, that volume of resection was considered. So higher levels of resection, colorectal trained, local recurrence 10%. Because what you would say inherently is, okay, so colorectal surgeons operate on lower tumors. Well, maybe they get a higher local recurrence. Well, no, it's the converse. They get lower local recurrence. And the high volume colorectal surgeons, higher volume, got the lowest local recurrence rates. The lower volume colorectal surgeons did more or less the same as non-colorectal trained high volume. And the worst possible scenario in Canada at that time, with almost a 50% local recurrence rate, was to have your surgery by a low volume, non-colorectal trained individual. The same thing was true for disease-specific survival, to the point that on multivariate analysis, the hazard ratio for local recurrence was 2.5 for non-colorectal training. Same was true in the United Kingdom, 3.5 times more likely to have a local recurrence if operated on by a general rather than a colorectal surgeon. And around the world, this was found. You can see the different countries. Higher volume surgeons gave their patients lower rates of morbidity, lower rates of mortality, and lower rates of local recurrence. What about specifically in the US? Rocco Riccardi, when he was at the University of Minnesota in training, looked at the nationwide inpatient sample and found that 60% of patients in the US ended up with colostomies. And that's kind of a little bit of a frightening statistic, because we know that not 60% of tumors are invading the anal sphincter muscle. So why is it that high? He then looked by county level. So these are different states in the US. This one's Michigan, here's Florida, where I am, many populous states. So New York, California, Florida, and basically found that only 20% of counties in the US had colostomy rates under 40%. Very, very sobering indeed. And the surgeons who were more likely to perform restorative resections were specialized surgeons. So just like the Canadian study, higher volume and training conferred better opportunity for the patients. In addition, these high stoma counties were less likely to have teaching hospitals, MRIs, PET scanners, and the like. So the patients weren't going to have the same opportunity. Globally, in the US, when we look both at our national data and at our California database, we found that the rates of colostomy in the US were higher than anywhere else in the world in similar studies. And despite taking out the sphincters, we still had the highest rates of circumferential resection margin positivity from our national cancer database compared to France, UK, all these other countries. So can introducing a national program help? Well, yeah, the late Lars Pahlman showed that introducing rectal cancer care, restricting it to colorectal units, decreased the recurrence rate, local recurrence rate, from 47% to 13%, and improved survival. Subsequently, in Sweden, it was found that this centralization improved both 5-year and 10-year overall survival rates. Nearby in Denmark, Stefan Bulau found that 5-year relative and overall survival rates improved with a national program to centralize care. So as these centers of excellence in Europe popped up, the authors of the different studies found better adherence to total mesorectal excision, lower rates of permanent stomas, lower rates of local recurrence, and higher rates of overall survival, which led us in 2011 to establish a group to get around a table on multiple occasions with representatives from all of these different organizations, representatives from around the country, different practice types, different places in the country, representing different groups, and start to put in the literature a variety of awareness articles about problems we had in the United States with rectal cancer care, and trying to pitch the idea that a national program could work here too, despite the problems of insurance programs. The group to whom we turned with our idea was the American College of Surgeons, because in our almost 110 years of existence, the American College of Surgeons has created many programs. This one is now the Joint Commission. This was an ACS program, Commission on Cancer. We're about to celebrate our centenary for the Commission on Cancer. You're familiar with many of these different groups. So in 2014, I had the opportunity to present to the accreditation committee of the Commission on Cancer, of which I was a member at the time, the idea of this program. It was soundly approved after 3 years of us doing preliminary work and publishing articles. I then had the opportunity to present it to the Board of Regents, the American College of Surgeons, who approved funding and creation of the program. We spent the next 3 years, 2014 to 2017, creating the standards manual for this program. In 2017, we did beta tests of sites, and in 2018, we began the formal accreditation process. We would be this June starting our reaccreditation process were it not for COVID. So all of these programs, everyone here, people who've been given one extra year accreditation because of COVID. One of the wonderful features of having our program through the ACS and the COC is all of our data goes into the National Cancer Database, which is the world's largest cancer database. There are now well over 40 million cases. Each one has 250 data points. It's basically an infinite amount of information. Using the NCDB, we can find a lot of interesting things, such as significant variations in the use of evidence-based care, variable through the country, and worse in low-volume centers, like everything else we've been discussing, best in high-volume centers throughout the US. Similarly, we can find through the NCDB that our CRM rate nationally is 17%, and that is a very unacceptably high number. So what is the NAPRC? All of the programs that I showed you on that list of American College of Surgeons programs work by having a process in place, and then after after the process, you start looking at performance, right? So you have different types of measures. First standards, I'll show you a little better in a moment. The first standards are what you need. The second is how you do. The NAPRC, which was officially commissioned, if you will, in 2018, includes these different groups with representations from all of them, including the American College of Surgeons Fellowship. So the program management are really the process standards. Standard 1.1, you are accredited by the Commission on Cancer. Otherwise, you cannot be NAPRC accredited, which is different than the National Accreditation Program for Breast Cancer, which you can have that independent. We wanted COC accreditation because it ensures a baseline and eliminates the need to duplicate services. Then there's the performance standards. How do you do with these different fields? So here's easier to see it in this format, but these are the requirements to have the program in place. And then this is what you need to do. You don't treat a patient without looking at the path report, ideally looking at the slides, staging the patient with rectal cancer protocol MRI and CAT scan of chest, abdomen, pelvis, as we just discussed. These are the building blocks to do your surgery. And when you're done, you look at everything as a team again. You reflect on what you did and what you could possibly do better. A big cornerstone of our program is using synoptic reports. We know that when a synoptic report from an electronic medical record is used, we can increase the amount of information captured from around 46% to almost 100%. Takes a few minutes, but it is standardized and it ensures we do not forget to put elements in that report. Arden Morris from Stanford created our report for us with her team, and you can see the fields that we capture here. the things that you would normally put in a free text narrative operative report as listed here. And each of these is a pop-up. So when you're in Epic, you can click each one and you can fill in the blank, fill in the answer. These are data from Arden Morris. This is one of her fellows, Samantha Bidwell, just published. 37 surgeons from 14 institutions. We tried this report as a beta test. We submitted the reports, and basically you can see then people were interviewed. So you use the report and then you're questioned about how you did with the report. And prior to implementation, certain features which we think are important were captured in less than 50%, just like the other study I showed you. And after implementation was more than 89%. So we almost doubled the data capture by using these reports. And it was pretty quick and pretty easy. It's not anything new. The pathologists have been doing it for a while, specific to the elements which we assess: relationship to the anterior perineal reflection, intactness of the mesorectum, distance to the CRM. The pathologists significantly increased their data capture from 76 to 90% up to 100%. Here's another example. Rectal cancer operative reports from June to December 2018 from 10 hospitals in the Michigan Surgical Quality Collaborative. So you look at these reports. So 28% had all the elements we need in our report, okay? Then when a synoptic report was used, suddenly you shot up to 92%. Huge difference in the capture of data with the synoptic report. And that serves many purposes. It lets others know what we did. It lets us compare data. It lets us put more accurate data in the National Cancer Database. Another facet of the program, which I think is incredibly important, is specimen photography. Just like we're having this meeting today with more than 2,000 people online, every Monday from noon to 1, we have our National Accreditation Program for Rectal Cancer Multidisciplinary Tumor Conference. We don't have more than 2,000 people, but we certainly have many, many, many people, both live and now with COVID online. So just like we're looking at these screens, they're looking at their screens, they're looking at images, and they're seeing how we did as surgeons. With more than 2,000 people online, every Monday, noon to 1, we have our National Accreditation for Rectal Cancer Multidisciplinary Tumor Conference. We don't have more than 2,000 people, but we... What just happened there? Okay, let's try again. I just heard myself in delay. Basically, a great motivator to perform great surgery is knowing that everyone's going to look at your specimen on a big screen. And when Mariana Barrow or Pablo Bejarano get up there and they show our specimens, we want them to be great specimens. So it's a learning experience for us as surgeons. It's a quality verification tool for us as surgeons, but it's also quality verification for the imagers. So for example, here's tumor that we thought was invading the prostate, and we get, this is a transanal TME with en-bloc prostatectomy. And we went back and we compared and we said, what's our level of accuracy here? This is a phenomenal tool. Here we have extramural vascular invasion. We look at it here. Exact, wonderful correlation for the imager and the pathologist. So we can tell, is our TME complete or near complete, or is it incomplete? That's really, really important. The problem, it turns out, is that if we try and grade ourselves as surgeons, it's a bit like an open book test where you say, oh yeah, you did a great job, you got an A, pass. But when somebody else grades us, it's suddenly not always an A. And in fact, when the pathologist said the TME was incomplete, it correlated with local recurrence and survival disadvantage. When we said it, it didn't. And you can see that difference here between surgeons and pathologists looking at mesorectal, intramesorectal, and muscularis propria. So basically complete and near complete do very differently than incomplete when the pathologist says so, not when we say so as surgeons. Can you do it quickly? Yeah, according to Ara Darzi, about 3 minutes per case. And in this study from Cleveland Clinic main campus, they had an interesting experiment. They asked all the surgeons who'd seen these patients in clinic, 408 patients, they'd been seen in clinic, and the surgeon had an idea in mind of what they wanted to do. And then they surveyed the surgeons after the MDT and found that in around 1 out of 4 cases, the surgeon changed his or her plan based on the wisdom of the crowd. And that change was not only by junior surgeons, but by surgeons in all stages of career, which highlights the importance of having these discussions. And that's what I tell my patients. You know, yes, I've been doing this for 35 years, and I'm happy to tell you what I think I'm going to do, but I'm going to defer till Monday from noon to 1 when we sit down with a huge room full, or now online, many people from radiation oncology, medical oncology, imaging, pathology, surgery, genetics, maybe liver surgery, maybe spine surgery, whoever we need. And we're going to talk about it as a group, and we're going to come up with a recommendation. How compliant are we? Well, we looked at a voluntary survey and found that only 27% of responders had compliance to go. But compliance was highest, like we've said many times through this lecture, in high volume centers. Best in high volume centers. Excuse me, there's a recurring theme there. So that was a voluntary questionnaire, and we all know the value of voluntary questionnaire. So let's turn back to the National Cancer Database and see how people actually did. Not what they said they were going to do, but what did they do? And let's look at our performance measures of, again, margins and nodes. And what we found is that there was only a 28% process measure compliance. Now that's interesting because that's very similar to the voluntary survey, almost identical. So people seemingly were actually being forthright with their responses. And when we looked at the further performance metrics, 56% for reporting the negative CRMs to be negative. By the way, pretty much the same as we found in the NCD Bay survey, also 17%. So there's a lot of room for improvement there. Currently, these are the accredited programs. The first one in the country was this one out in John Muir in the Bay Area in San Francisco. We were the second to be accredited, but there's now another 53 programs awaiting accreditation. Now, the COC has roughly 1,800 accredited hospitals, at which approximately 70% of all newly diagnosed cancers of any type in the United States are treated each year. Out of that 1,800 programs, we estimated about 200 would ultimately want to be accredited by the NAPRC. So once we get rid of this COVID backlog, we'll be up to maybe 80 programs, well on the way to what we thought would be 200. So I've tried to hustle through to make up a little bit of time in the schedule today, but I'm very, very pleased that we've been able to, in a mere 10 years since we started this concept, achieve the point where we now have hospitals from California to New York and Florida, from Michigan to Texas, the entire country, big hospitals, little hospitals, university hospitals, clinics, cancer hospitals, all applying for accreditation in our program, because it validates that what we set out to do to improve cancer care throughout the United States is becoming a reality. And I certainly hope that a similar program can be introduced in Brazil and elsewhere in Latin America. Even if without the accreditation process, you can probably do what has been done in Israel and India, and that is just adhere to the standards anyway. You know what's required, just do it. Even if you don't have local COC or NAPRC accreditation, following those standards will get you the same results. So again, Raul, my dear friend, thank you very much for including me again today, and I send you a virtual hug in the absence of being able to give you a real one this time. Hopefully we'll see each other soon.